Hello, I'm Dr. Jay Noreen, and this is App TV's Health Talk. Diabetes has been perceived by some to be fairly uncommon, but in fact it's quite common and even more today than in the past. Some say an epidemic. So what's going on? We're lucky today to have with us to provide some answers two physicians from Appalachian Regional Healthcare Systems, Baker Center for Primary Care, Dr. Julia Sherrill and Dr. Jason Crawford. Welcome to Health Talk. Good to have you here.
Thank you.
I wonder if we could start by, if you would tell us a bit about the nature of your practice in the Baker Primary Care Health Center, and it would be great if you could tell us a little bit about how'd you get into medicine in the first place. Jason?
Yeah, I think we can talk first about the Baker Center for Primary Care. The namesake is Dr. Charlie Baker, who has been a stalwart physician in our area for, I believe, 34 years, and I believe he's touched every area of healthcare in this area. His name shows up on people's lips quite easily. I will have people say, oh, he delivered my mom, he delivered me, he's delivered my children. So we're a primary care practice located in Linville. We have 4 physicians, several nurse midwives, and nurse practitioners as well, providing essentially comprehensive healthcare needs for pediatrics all the way through geriatric care, and including prenatal care as well. As for me, my personal interest in medicine began actually in high school. I grew up in Asheville, just down the mountain, and I remember that I was determined to become an engineer, but in the process of undergoing some volunteer experience at Mission Hospital there, I realized that I much more enjoyed working with patients and people and the problems that they experience, and realizing that I could touch their lives in a personal way would have been less satisfying in an engineer background.
Yeah,
and that was the end of the story for me.
Interesting, interesting. We have something in common. I started out in engineering before medical school as well. Dr. Sherrill, Julia, what about you?
Also, at the same practice as Dr. Crawford, definitely full scope family medicine, any newborn till 100 plus, So anything and everything in between, for sure. I think I can't even hardly remember what got me into medicine other than a wonderful pediatrician that I had. I remember him telling me to go to college, even if it was basket weaving. So he was very influential just in, making his point that it was very important for me to get an education. Mm-hmm. And then I couldn't imagine doing anything else other than that. People have asked me, what would you do if you didn't do medicine? I don't know, because that's what I love to do.
That's great, great. Well, I'm sure there are students out there who are thinking of medicine, and to hear your stories is very helpful. We are going to talk about diabetes today. And I know you cover an awful lot of other things in your primary care practice, but I know this is a big one as well.
It is.
So we have an audience out there, some of whom are diabetics, and we have an audience out there of people who probably don't know much about diabetes. So I wonder if we could start by talking about, what really is diabetes? Can you just kind of give us the short version of what diabetes is?
Yeah, so diabetes, put in a nutshell, is a deficiency in the body's ability to deal with sugar, plain and simple. There's essentially 2 different ways that shows up. There's a hormone called insulin that is used to help regulate sugar in the body. So some patients with diabetes are unable to make insulin for one reason or another. Other patients do make insulin, but for reasons that are yet to be fully understood, the body just doesn't respond as well to insulin. So they end up having similar problems of sugar levels too high, as well as the long-term complications that can go about from that.
Mm-hmm. 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 What, for the person out there who might have a family history of diabetes and might be concerned about, am I likely to get this disease, what are the symptoms that sort of precipitate and begin to make people think about this? What are the key symptoms?
Some of the first symptoms can just be increased thirst, increased urination, increased hunger. All those can be some of the symptoms associated with diabetes, which could definitely go unnoticed because it could come on gradually and you would not have much idea that was something to be worried about For someone with type 1 diabetes, that can be a lot more serious because the first instance they might have a problem might be because they end up in the hospital. But for someone with type 2 diabetes, which is what people are probably a little bit more familiar with, or what people consider adult diabetes, even though it's not just adults anymore, can be a very gradual process. So there's not always a symptom that's clear cut that they say, wow, something's very different all of a sudden, because it can come on gradually.
I'd like to come back and talk a bit more a little later about the type 1, type 2 adult child and what that's all about, because I know that's something I think is not well understood by the general public. But can you give a sense of how common diabetes is? What's the nature and prevalence of it in the country, and is it different in North Carolina, or this part of North Carolina specifically?
Definitely
The sense of that?
a little different here actually than the whole country. In our country, it's around 9% actually of the population, which is 29 million people.
That's a lot of people.
And that's just growing every day. In North Carolina, it's almost 11%, so quite a bit more than the general population.
Yeah.
In Western North Carolina is a very similar population to that, almost 11% of the population. And many of those people don't know they even have it.
Yeah.
So it could be very serious.
It's an impressive number. What is it about North Carolina that makes it a couple of percentage points higher? I mean, a couple of percentage points is a lot of people.
Right.
That's a surmise without having data at my fingertips that a lot of that may come down to diet, activity, which are, and we may talk a little bit later about ways to prevent diabetes from coming on. So obesity is a risk factor for diabetes, and genetics can play a role in that, particularly with type 2 diabetes, and there are some other risk factors that just may be a little bit more prevalent in our area. I may even be able to tag on to some of the numbers that Julia was able to share with us in terms of the economic burden of diabetes in the United States. The American Diabetes Association ran a study in 2013 and determined that for the year of 2012 alone, the cost of diabetes in the U.S. was a staggering $245 billion. Over 2/3 of which was directly responsible for medical care of diabetes, and another third thought to be responsible for lost productivity in terms of time off work, being unable to work, or even passing away early because of complications of diabetes. And that's actually over a 40% increase from the estimate in 2007. And it's estimated that if we continue with current trends in the number of patients developing diabetes, that 1 in 3 American adults will have diabetes by the year 2050. It's clearly a significant problem for us.
Right.
That is very impressive. 240 billion.
Correct.
Just to emphasize, with a B.
With a B.
Big B.
240 billion.
Yeah.
That's pretty amazing. You know, the cost of Medicaid nationally is, I think, around twice that, about 500 billion. And that's everything Medicaid. So that is a very impressive number. And going potentially to 1 out of 3 as opposed to 1 out of 10, as we're talking about now,
Right.
1 out of 11 maybe. That is very, very impressive. What can you say about what's the process of diagnosing diabetes? I mean, you mentioned that there are certain symptoms that make you think about it, but then what happens if I've got some of those symptoms and I'm worried, I go to my primary care physician at the Baker Center or elsewhere? What happens? How do I get diagnosed?
So if a patient comes to us, for say you came to us and told us that you were very thirsty, or drinking water all night long and having to go to the bathroom a lot, we would definitely do a physical exam, but the diagnosis is going to be made through blood work. So you would have lab work. First off, probably a fasting blood sugar, and fasting just means that you haven't eaten for 6 to 8 hours before you have that test. And if that blood sugar number is over 100, then there's a higher likelihood that you have diabetes.
Okay.
And then there's another test that can be added on. It's just called a hemoglobin A1C. And all that really is an average blood sugar for 3 months. So you're able to pick that up amazingly through a little bit of blood work. And that number can also tell us we can use that now to diagnose diabetes.
Okay.
In
Now-
addition to that, if I may, we do have guidelines helping us out with diagnosing unrecognized, essentially asymptomatic diabetes. You know, if you have certain risk factors such as a strong family history, high blood pressure, obesity, advancing age, those are all reasons for us to check on an infrequent basis whether or not you have diabetes using either of the methods we talked about already.
Right.
So I think it's very important to stay in contact with your primary care provider just for those routine preventative visits so we can catch those sorts of conditions.
So on a routine visit, annual or biannual physical or whatever it happens to be, there's usually a battery of tests done.
Right.
And blood sugar would often be among those battery of tests. And so if it's
Yes.
a little high, then you would go to the fasting
Right.
test.
Right.
Or the A1C or another test. But just on your routine exam, when you see your physician, if it's emerging, you'd probably know about it, right?
Right. Yeah, we're gonna pick that up.
You're going to pick that up. So another reason to go and do that
Right.
periodic.
So if you're not going, then we don't know.
Health exam, right? Yeah, because you might pick it up. And now one of the things you mentioned is a lot of people that are pre-diabetic or are diabetic, especially type 2, as what's been called type 2, they don't know it.
Right.
What proportion of the people out there that are in that category approximately, I know it's hard to know, do you think, what are the sense of how many people don't know it that are emerging to be diabetics?
So actually, the CDC has some thoughts about that, and going along with that 29 million, they think at least 8 million of those people have no idea
That's a big number.
that they have diabetes.
Big number.
And it's even larger that could have pre-diabetes,
Yes.
which is
But again, that
Very
gets
common.
picked up on a normal periodic exam.
Right.
That I'm sure you do
Right.
a lot of those in your practice.
We do.
Yeah. Good. Well, you mentioned earlier the types of diabetes. Can you explain that a little bit more for the general viewer?
right. So type 1 diabetes is unfortunately not something right now that's preventable. There's not prevention like type 2 diabetes has. If you have type 1 diabetes, your body just is not producing the insulin. So there is not a medicine that you can take to make your body produce more insulin. At that point, you have to be on insulin injections.
Yeah.
And that is typically diagnosed in childhood. Occasionally, pretty rarely, it could be diagnosed probably early adulthood, but usually it's a childhood illness. Unlike type 2 diabetes, which used to be considered adult onset diabetes, we're seeing more and more of that, especially in teenagers, because of obesity being one of the biggest risk factors for that. With type 2 diabetes, you just become less and less sensitive, and you're also producing less insulin. So there's a lot of just a continued progression that your pancreas, which is an organ in your body, is not producing those hormones like it should be.
And now the history of this is that we used to call diabetes juvenile
Right.
diabetes and adult onset diabetes
Right.
because the insulin absent, the type
Right.
1 that comes in kids, the type 2 usually didn't used to happen in kids.
Right.
But as you're saying, what's happened now is that kids are increasingly
Right.
acquiring type 2 diabetes.
Right.
And so we've kind of changed the terminology now. We call
Right.
it it's not adult onset and juvenile, it's type 1 and type 2 because
Right.
of that.
Exactly.
One of the things that I wonder about, that I've read a bit about, is that type 2 diabetes in children has increased a lot, as you've mentioned.
Right.
But in some other countries, it's increased even more rapidly than in the U.S. But it's become a very serious problem.
Right.
So for parents, it's really important to be aware of this, that type 2
Right.
diabetes happens to kids now as well.
Right.
So it's a critically important issue. Can you talk a little more about treatment? You of course mentioned injection insulin for type 1,
Right.
for what used to be called juvenile diabetes. Can you talk a little bit more about the rest of treatment, especially type 2, that kind of treatment, which isn't so much insulin? Can you
Right.
talk a little about that, just kind of as a summary?
Yeah, sure. There's there's a lot of treatments now. There used to be not very many. Insulin was actually it for anybody with type 1 or type 2 diabetes for a long period of time. I think you had a date on that.
Somewhere in the 1950s, if I remember correctly, when regular insulin became widely available.
Right. And then we got metformin, which is a medication that essentially does make you more sensitive to the insulin and hopefully helps produce less glucose, which is blood sugar in your body. And now that has greatly expanded. There's many different oral medications, which means medications taken by mouth, that can be used for type 2 diabetes, which most people like. They like that they could take something by mouth
Yes.
before going straight to having to give themselves injections. Most of those medications either make you more sensitive to the insulin you make, try to help you make more insulin, or try to just lower your blood sugar. There's even new medications that are supposed to help you lower your blood sugar by urinating it out. You know, it's amazing, these new treatments that are coming out to help lower blood sugar before starting insulin.
I think in keeping with our philosophy in family medicine is that we look at the entire patient, and diabetes is no exception to that. We recognize that diabetes is what we call a coronary artery risk equivalent, meaning it's essential or equivalent, I should say, to other major risk factors for having a heart attack or a stroke. So it's not enough just to talk about treating the sugars, bringing the numbers, the A1C into target. It's also important to talk about blood pressure control, cholesterol control, making sure that we're screening for kidney disorders, trying to reduce the risk of serious infection or complications from infections such as pneumonia, influenza, hepatitis, things like that. So in addition to those medications, we recognize that other medical conditions should be optimized to try to give you the best chance of a long, healthy life.
It's very rare, it seems like, that somebody just has diabetes. There's usually other medical problems that go along with that, usually related to obesity.
It's the concept of risk factors. Diabetes is a risk factor for coronary artery disease, and hypertension is a risk factor. But you mentioned something that I think it's worth talking a bit more about, and that is, what can you do that can help prevent the onset of diabetes, or once it's there, can help treat it beyond medicine? What other things are most important with regard to what you can do besides taking the pills, the oral medicine for type 2 or the insulin for type 1, but particularly for type 2? What other things are important for the person with type 2 diabetes?
I think lifestyle modifications is our watchword. We use that for many medical conditions, but in general, we should all be eating balanced meals and moderate in all the things that we love to have: carbohydrates, fats, proteins, a little salt, things like that. In general, just watching what you eat, specifically for diabetes because it's a problem of sugar. We watch the carbohydrate intake. But we find that getting enough physical activity, which is usually characterized as more than 30 minutes of moderate intensity exercise 3 to 5 times a week. And I guess I should say that with the caveat that that's with the blessing of your physician, who may know more about your particular healthcare profile and whether or not that's a safe activity level for you. But in general, principles such as watching what you eat, how you exercise and move about, cutting back on smoking, quitting altogether, which has many more health benefits than just assisting with diabetes. Checking your feet daily, actually, is a great way for current diabetics to make sure that they haven't developed infections in the foot or skin breakdown that they may or may not be able to feel. I did a lot of background reading on whether herbal supplements and other forms of complementary medicine are effective. And like much of the supplement field, there's not a lot of strong quality research to guide us one way or another. The consensus seems to be that there are no high quality studies showing that any herbal supplements whatsoever help with prevention or treating current diabetes, and that includes a long list of substances, probably the most common being cinnamon, ginseng, garlic, chromium, vanadium, all of which are probably beneficial, but there are some substances that have been shown to cause harm in excess from what you would ordinarily obtain.
Which I add, that's why you should always also tell your doctor if you're taking supplements, because those could interact with other medications you're taking, and that really does affect the treatment.
Well, this is an important topic because there's so much in the, the regular general media about such things as supplements and herbal medicine, herbal supplements and that sort of thing. It's important to remind people that those things have not been fully analyzed. And
Right.
so it gets back again to those risk factor things you were talking about.
Right.
The plain old simple diet and exercise remain critically important. One of the questions that I often get is, when you say moderate exercise, what does that mean? Does that mean I have to run 3 miles 3 times a week? Or what is moderate exercise? What's that level? I think a lot of people get uncomfortable with moderate exercise thinking you have to be, run 10 Ks or something like that.
Definitely not that intense. I think 3 miles or 10 miles, that's definitely probably more in the strenuous category for our general population. But moderate, you definitely need to get your heart rate up. This is not just, walking down the street. Walking down the street at a little bit higher pace, getting your heart rate up, maybe getting to the point that you wouldn't be able to have a complete conversation with somebody without feeling maybe slightly short of breath with trying to talk and exercise. That might be kind of a clue that you're at that level of moderate intensity.
Okay.
I would agree with that. There are heart rate targets that you can aim for based on your age if you want to get very technical about that, and you have a way to monitor your heart rate while you're exercising. But I think for most of us, moderate intensity, you get a good sweat on, you finish it, you feel good, but you don't feel like you need to go take a nap for 4 hours.
Right. Well, and there's been, I've read recently that even a good brisk walk
Right.
is quite beneficial.
Yes.
But you have to do it long enough. As you say, 30 minutes 3 times a week or so. But even a brisk walk is good, not only for
Right.
the issues that we're talking about, but for a lot of other health issues as well. So one of the things that I think is important as well is for the newly diagnosed diabetic or long-standing diabetic, what are the kind of community resources that they can rely upon? And you know them locally. What kind of things are there that will help people?
Well, certainly endocrinologist is a specialist who manages endocrine disorders, which includes diabetes, would be a wonderful resource to have. We unfortunately don't have any endocrinologists located in Boone or Linville or immediately nearby, but there are referral centers at major hospitals such as in Johnson City, Asheville, Winston-Salem, et cetera. But there is a group that encompasses diabetic teaching, so specifically how to control your sugars, how to do injections, how to count your carbohydrates, how to eat. Nutritionists help out with that a lot. And then there are support groups for people with diabetes, for parents of children with diabetes located here in this area.
Sometimes even like that families can go, if they're trying to help their loved one, even if it's an adult, that they're all trying to work together to eat better and support that person that has been diagnosed.
I think one of the greatest resources would be the American Diabetes Association. They have a fabulous website with lots of recipes that are great for individuals with diabetes, or if you're just interested in trying to prevent that,
Right.
How to connect to other support groups outside of this area.
Yeah.
It's a terrific resource.
Okay, that's good to know. The American Diabetes Association website, again, everybody can get access to
Yes.
that quite easily.
Yes.
And I know these are really very, very valuable resources. The people who are at home and have, particular type 1 diabetes, I know you teach them to monitor their own blood sugar. How does that work? And for for type 2 as well, how do people learn how to do that, and how complicated is it?
They actually have classes for that too, but it's usually fairly simple. Even the device itself comes with directions. It does include, of course, having to usually use a fine needle, but you don't see it. It pricks your finger, and you get a small drop of blood that goes on looks like a little strip of paper that goes into a machine that tells you the number that you're looking for. And of course, then during usually classes or during your visit with your physician, they go over what your goals are for, say, when you first wake up in the morning, what it should be a couple hours after you eat, so that you can monitor that yourself, which is especially important, of course, in all diabetes, but in type 1 diabetes, especially just because of the increased risk of.
We as providers use that information to decide where patients are in terms of getting optimum control, and we can adjust your medications as we need to just to help you out with that and make sure that we're not over-treating you as well, so that we're safely giving you these medications.
There's actually more risk involved with low blood sugar affecting affecting your brain actually and how it's functioning than high blood sugar. Neither is good, but low blood sugar can be actually even worse. So, and that's even more important as people age. So something we definitely like to monitor closely.
Well, thank you very much. This is great information, and I know the people out there who are listening and watching are learning a lot that they didn't know before, and so this is a great service to the community. We hope to have you back. We'd like to talk about the many other primary care issues you deal with every day. I know we've talked about hypertension. We'd love to do that another time. I hope you'll be willing to come back.
Sure.
Thank you very much.
Thank you.
Well, that's our program for this week. If you have questions or comments, you can contact us at watchapptv.com. And please join us throughout the week on Health Talk. I'm Dr. Jay Noreen.